Hey everyone, welcome to Medicine 3.0, where we talk about healthcare, AI and healthcare, and how you can achieve your optimal health. Super excited this week. I've got my partner, Kat Isaac, Dr. Catherine Isaac, who will be talking about women's health and in particular, women's hormone health around menopause. So sit back, listen up, enjoy. Here we go. And now, welcome, Kat Isaac, to the podcast. You know, I had to start with an awesome intro. So, Kat, welcome to the podcast. I'm excited to dig in. How are you doing today?
I'm doing great. I'm happy to be here.
All right. This is something that I swear. So you joined Bionic Health, and I told you, like, we all have to be complete experts at female hormone health. And as soon as you started digging in, like, that was like, I haven't heard a word out of your mouth that wasn't like, hey, did you know this about female hormones? And often I did not. So I'm super excited. I consider you our resident expert on all things female hormones now. So super excited to dig in on this. I'm curious, as you've kind of gone on this journey, retrospectively, what do you think about kind of female hormones from where you were 6 months ago to where you are today, and how you think about things differently?
Wow. It's been I was going to say it's been a long journey, short journey, but a long journey over a short period of time. That's what I'm trying to say.
I got it.
I think I've come pretty far in terms of my understanding, and every time I was learning more, I would feel this sense of almost disappointment in myself for like, wow, you had no clue about this, that, and the other thing. And yeah, I mean, I'm thrilled that I have so much more knowledge under my belt now, but definitely realized that I was operating with really, I guess, old information or inaccurate information, and not necessarily all my fault in that sense, in that I think many primary care doctors and other physicians received limited training on menopause and menopausal treatment. And actually, I was going through medical school. I started in 2003, which was a year after the Women's Health Initiative came out in 2002. And I remember sitting in a journal club talking about the Women's Health Initiative and feeling confused at that time. And yeah, so I'm happy that I've been able to really make this the focus of my efforts recently at Bionic. And you know, I know that a lot of primary care doctors, overwhelmed as they are, would really appreciate learning more about this. And I will also say, given this time in my life, I am really appreciative to be learning this information, as I understand that it's affecting me as well.
You know, I had a conversation with one of our favorite people in female hormones health, Dr. Mary Jane Minkin from Yale, Madam Ovary. And she said that in OB-GYN residencies today, the average is like 2 hours of training on menopause for OB-GYN residents. They should be the experts on this. So I don't think I understand feeling bad as a primary care provider, feeling like you weren't completely up to date. But I mean, when our resident experts are not getting adequate training, it's no wonder that general practitioners are not getting adequate training in this space.
Yeah, definitely. That's good to hear. Thank you.
Yeah. So, well, let's jump right in and talk about some of the interesting things around menopause, perimenopause. You know, it can be such a prolonged period of time that I feel like so many women fall in that gap. So let's first just talk about what could that year range look like? What ages could women start experiencing perimenopause to menopausal symptoms?
Absolutely. Yeah, so the first thing for people to know is that the average age of menopause in the United States is 51. but there's a very wide range in which a woman can experience menopause. And to even take a step back from there, let's just explain that menopause happens to be 12 months after you've had your final menstrual period. So that's really what that statement indicates. You haven't had a period for a full 12 months, and that's when you're officially in menopause. So we're not necessarily looking at any lab tests to make this determination. It's really what we call a clinical diagnosis. And perimenopause is the period in a woman's life where she begins to have menstrual irregularities, meaning her periods become irregular or she starts skipping periods, and she can start to have symptoms associated with her hormonal changes, because what's happening is she's losing the usual cyclic change or cyclic production of her estrogen and progesterone rather, that would happen over her monthly cycle. So menopause, again, that 12 months after your final menstrual period, perimenopause, the period of time when a woman starts to experience symptoms related to those hormonal changes. And what's so interesting is, as I said, age 51 being the average age for menopause, but it could be anywhere between age 40 to 53. That's the common range. And 1% of women have entered menopause by age 40. 5% of women have entered menopause by age 45. So that's still a good number of women who are going through these changes. Another interesting thing that can make it kind of difficult to make this diagnosis, or for a woman to even know if she's in the perimenopausal period, is if she's on birth control of some sort. So a lot of women are on birth control and have been for quite some time, or they may have an IUD in place, so they're not getting menstrual periods. So they don't have that cue that things are starting to change to think about, wow, this could be when I'm starting to enter that period of time. Another interesting factoid, Jared, is that women can have perimenopausal symptoms for 4 to 5 years before onset of menopause. So it's not something that's happening within a brief period of time, and then, they just go over that limit of the 12 months, but rather it could be years of having symptoms related to these changes.
Yeah, I was going to say, so if you think about, 40 being, 1% of women and up to age 53, and if you're thinking 4 to 5 years before menopause, you're having symptoms, we're really talking about like a 17-year period for women that they're going to fall somewhere in there, start having symptoms. So it could really be a pretty significant chunk of like adult women in the US or in the world that are going through these symptoms at the same time. It's kind of remarkable.
Yeah, absolutely. And, what was surprising to me when thinking about that information was that there are a number of women, again, a small proportion of women, because as I mentioned, only 1% are going into menopause at 40. But that means that 1% of women are experiencing perimenopausal symptoms before age 40. So it's not something I think that we necessarily consider when we have women coming into the office with a variety of non-specific complaints.
Yeah, and I really like that you pointed out so many women are on birth control, and how confusing that could be to be having some sort of non-specific symptom that very well could be perimenopausal symptoms, but how would you know? So let's talk a little bit about what are some of the symptoms that women are having when they go through perimenopause.
Sure. So most classically, people think about vasomotor symptoms or hot flashes. That's what we commonly refer to them as. Hot flashes and night sweats. So that can be very bothersome, can happen multiple times throughout the day, multiple times throughout the night. For people who have it very severe, they can be waking up drenched and having to change their clothes throughout the night. So that is most commonly what we think about. Other symptoms that women experience are changes in their sleep. So instead of being able to sleep through the night, now waking up during the night, and not having that necessarily restful, restorative sleep that they had before. That also could be disturbed purely by the fact that they're having hot flashes as well during the night. Other symptoms that women can experience: brain fog, not being able to think clearly about something or recall facts as easily as they could before, certainly fatigue. Joint pain was a very interesting symptom that I learned about. Had no clue that experiencing joint pain is something that a perimenopausal woman or menopausal woman might start to have and indicate a change in her hormones. Palpitations. So palpitations meaning like feeling like irregular heartbeat or fluttering in their chest. And of course, you'd always want to rule out that there's any underlying cardiac cause for her symptoms when she's presenting with that. We don't like to make assumptions about why someone's coming in. And mood changes as well. So people can experience increased anxiety and depression, and particularly women who've had a history of depression or postpartum depression are more likely to experience a depressive episode during the perimenopausal and menopausal period. I was going to go on to say something else interesting that I learned about that. So women who are in the perimenopause and menopausal period are actually at increased risk for developing alcohol overuse. They're trying to cope with some of the symptoms that they're experiencing. So it's something to be aware of.
That is super interesting, and it makes me curious. I know a lot of people over kind of the pandemic started to struggle more with drinking, and it'd be interesting to look at if anybody's looked at females going through perimenopause during the pandemic, like if that was even worse for them.
I would imagine.
During that period. Yeah. And it's not surprising that women are trying to cope one way or the other, trying to figure out, like, and the difficulty in knowing for themselves, this is what's going on. And then going to their typical primary care provider or healthcare provider who maybe doesn't even have any of these symptoms on their radar as far as this is perimenopause going on. So what would trigger for you as a care provider? What would trigger to start digging in and looking, like, is this hormones rather than a mood disorder, or hormones rather than something else?
Absolutely. Well, I think one of the clues can be related in terms of sleep patterns that the person's reporting. And of course, with depression, you can have both depression and be in perimenopause. It's not necessarily one or the other. People who are experiencing a depressive episode will more often describe difficulty falling asleep and also early morning awakenings. That's a common symptom that people with depression can have. Whereas when you're in the perimenopause or menopausal period, you might more likely to be waking during the middle of the night. And oftentimes not having that difficulty falling asleep, because a perimenopausal woman might be experiencing a lot of exhaustion and fatigue. So they're falling asleep quite easily, but just waking during the night and then having some difficulty falling back to sleep. So that certainly can be a clue as to, one versus the other. I think also, sometimes what would be a good approach would be to consider treating one or the other and see what happens. So, SSRIs, the first line therapy for depression, while they can actually have some improvement on hot flashes, but if they're improving the symptoms and the woman's feeling better, then you can say, well, maybe we're not necessarily in perimenopause, or time will tell if that's going on. And vice versa. If a woman starts on menopausal hormone therapy and notices improvements in her mood and not feeling that she's struggling with that anymore, then that could be indicating that was the primary change that was triggering her symptoms.
Yeah. You mentioned, so number one kind of big symptoms we think about are these vasomotor symptoms. You mentioned a lot of kind of other symptoms that go along with it. I'm curious. So the FDA obviously has some symptoms they think that are indications for treatment, other symptoms that maybe they don't list as indications, but patient and their provider could still decide to start on menopause hormone treatment. So what does the FDA say these are indications for treating?
So the first indication is moderate to severe vasomotor symptoms. So moderate to severe hot flashes is an indication to use hormone replacement therapy. And I'll flip back between saying menopausal hormone therapy versus hormone replacement therapy. MHT is more in favor now in terms of terminology, but I'll probably flip back to saying hormone replacement therapy. So definitely moderate to severe vasomotor symptoms. Another indication can be prevention for osteoporosis for women who are at increased risk, although they're not totally clear on what they're considering increased risk. There's certainly women who are smokers, people who've been on long-term steroid treatment, and women who are underweight. And when researching that, I found it interesting that it was a BMI, I believe, of 20 or less, or a weight of 127 pounds. So that actually, I think, is important to know, that does indicate a risk factor for osteoporosis. And then certainly for women who experience premature ovarian insufficiency, which is a woman who experiences menopause prior to age 40. And if a woman has had her ovaries removed for any reason to cause ovarian failure, or radiation induced, I imagine would also be an indication. So the indications for therapy, I think, are pretty specific. And I find that interesting because there is ethnic variation of perimenopause and menopausal symptoms, meaning that different groups of women will experience different symptoms and severity of symptoms. So African American women tend to have the worst vasomotor symptoms, I think, followed by Caucasian women. And then women of Asian descent tend to have less vasomotor symptoms. I think, is it Filipino or Asian women in general tend to have more joint pain related to perimenopause. So, I think when you're just focusing on that one set of symptoms, it's not necessarily taking into account the fact that a woman can be having a whole slew of other symptoms, but we don't commonly think about that, and that they can be really upsetting her quality of life just as much. And that's one of the challenging things, I think, as well, because yes, you can sometimes see when women are going through a hot flash, you can see that they break out in a sweat. But the other symptoms are not necessarily visible to anybody else that the woman is experiencing. But that doesn't mean that she's not suffering any less because of that. So I think it's very easy as the doctor treating the patient to say, well, they look good, their labs look good, she's not sweating right now, I think she's okay, she'll make it through. But now having just a greater understanding of the impact of these symptoms on a person's level of function, I realized that, maybe it's actually better to have a broader indication for hormone replacement therapy than just those, 3 indications that I described.
Yeah, it's interesting to me. I feel like, and I don't know if this goes back to the Women's Health Initiative that maybe we can go deeper on another conversation, but it seems like the indications are such that you really kind of have to earn your way to getting treated. Like you have to be, moderate to severe. It's not, and it's not okay that like you have mild symptoms that are bothering you, and it's not okay. You're not going to qualify just for fracture reduction, but osteoporosis prevention. And so it's curious to me that it's like kind of so severe, at least the FDA indications. What would you say are other benefits that women report or that the studies report that they have from hormone replacement therapy other than just those things?
Absolutely. So one of the, in no order of importance, kind of just what's coming to mind. One of the common things that a woman can experience during this time is weight gain of 5 to 8 pounds on average. It tends to be more central weight gain as well, and that can be frustrating for many women. So women who are treated with hormone replacement therapy have been found to not have that weight gain that a woman without treatment could typically expect. Certainly when she starts on treatment, women can experience a reduction in pain and reduction in the joint pain. And interestingly, there are estrogen receptors and testosterone receptors in the joint, and there's actually a reduction in a frozen shoulder for women who are treated with hormone replacement therapy. And we were just chatting about that before. Other benefits, it has a positive impact, or it can have a positive impact on your lipid profile, particularly if you're using the transdermal estrogen. I believe they saw improvements in a reduction in LDL. I can't recall if there was an improvement in HDL, but also, interestingly, a reduction in lipoprotein little a levels for people who actually are predisposed to having elevated lipoprotein little a. Cognitive improvements. And I believe there's some data that suggests a reduction in progression to dementia for women who are treated with hormone replacement therapy. And then, of course, the benefits of bone health, so lower rates of osteoporosis.
Yeah. When you go through the list of like the positives, it becomes one of these things that in my brain, I start thinking, well, it seems like most every woman
Right.
would choose to go on hormone replacement therapy. What are the reasons that a woman, or that you would kind of counsel a woman to not do hormone replacement therapy?
Sure. There are certain contraindications to treatment, which include prior history of hormone-sensitive cancers, breast cancer, uterine cancer, ovarian cancer, and liver disease and increased clotting risk. So particularly oral estrogen, not transdermal estrogen, can increase your risk of blood clots. And that would be something that would be important to avoid. Smoking, as that can increase your risk, and migraine with aura, because patients who have migraine with aura, which is where they have symptoms, can have visual changes that precede a headache, a migraine headache, are at increased risk for stroke and clotting as well. So those would be particular times when you would want to avoid treating with HRT. I think it gets a little bit muddy when we think about people who do have a history of breast cancer, or history or a family history of breast cancer. Many women would be concerned that starting on hormone replacement therapy would increase that risk. And I think that, depending on who you listen to, that there's data that suggests actually estrogen could reduce risk of breast cancer or improve outcomes. So that would be a great conversation to have with our expert, Dr. Minkin, who could speak very eloquently about that.
Yeah. So when you think hormone replacement therapy, honestly, the ones that come to mind automatically are estrogen and progesterone.
Mm-hmm.
Where does testosterone fall in there? Like, why would it be important? Why would you think about replacing it? How do you think about that?
Sure. So it's interesting. Definitely women's levels of testosterone decline just as their levels of estrogen decline over time. And the impacts of that can be a variety of different things. One of the important things that can happen is loss of muscle mass or um, decreased ability to gain muscle due to the low testosterone. Certainly, women can experience sexual side effects as well, having low libido or difficulty with performance, which can be impacting their quality of life as well. Um, and don't remember if I have this accurately, Jared, if it can impact bone health as well.
Mhm.
But I think that's another important effect of the loss of testosterone for a woman.
Yeah. And I often think brain health also.
Mm.
You and I have laughed about this before, that the only, indication for women to have testosterone replacement is for hyposexual disorder.
Yeah.
Um, and so I've laughed like, okay, so the guys in the FDA, like as soon as like they're like, oh, that woman doesn't want to have sex as much with men, then they need testosterone. But
Right.
there are so many other good reasons. That does not seem like the only indication to me that women should need testosterone. So,
Yeah, I do. I'm glad you bring that up as well, though. Hyposexual desire disorder is the technical fancy name for it for a woman who's experiencing decreased libido. And we also didn't mention the genitourinary symptoms of menopause, where a woman can
yeah,
have vaginal atrophy. She can have increased risk of urinary tract infections. And interestingly, I think these symptoms are important to mention as well. A woman can have urinary frequency and urgency and bladder discomfort related to the decline in estrogen. And that one was like a big shock to me, to be honest with you, because I knew about the increased risk of urinary tract infections and definitely had been prescribing topical vaginal estrogen for a long time without any hesitation, but didn't realize that women can have those additional symptoms which would impair their quality of life, but not necessarily need treatment with an antibiotic. So, but I'm glad you mentioned the hyposexual desire disorder as well, because I actually think that that's quite underdiagnosed. As a clinician, up until now, had no clue that one, that was a diagnosis, and two, that would be improved with testosterone therapy for women. So that was, I think, really important to learn more about. And many women just sort of accept the fact that they're going to have a decline in their, uh, sexual function and sexual satisfaction, and just accepting that as a part of life. And now that we understand that women at age 51 or younger are experiencing perimenopausal symptoms, this is going to be affecting half of their life.
yeah,
Why is that not important? I actually think it is important. So I'm glad we're talking about that. And I think clinicians should feel more comfortable knowing that they can make that diagnosis by taking a good history. And not that you would go straight to testosterone therapy, you would also want to understand the whole psychosocial picture of that person and why they may be experiencing changes in terms of in terms of libido and orgasm, any pain during intercourse. So you'd want to address all the other things that may be happening in her life,
absolutely. Yeah.
but definitely not hesitate to treat with testosterone therapy for a woman if it is indicated.
Yeah. And it's crazy to think I like that you mentioned that most likely this is from age 51 on. And up to this point, we've kind of been okay saying it's okay that this woman's sexual health is kind of, she could have, like you said, vaginal atrophy, loss of desire, dryness, like she just feels terrible about her sexual health. And we've been okay just kind of saying, sorry, that's okay. That's just the way the cookie crumbles for you because you're a woman. Yeah.
Right, exactly.
Yeah.
Yeah. I definitely think that there's an implicit bias, probably even more so just thinking, well, it's not as important, or that patient is not going to think it's very important. And I think a lot of women will kind of shrug it off and say, like, oh, well, I'm good anyway. I don't need to have sex at this age. But if you told her, well, you might actually have increased sexual satisfaction, and we can treat that so that it's not uncomfortable, you're not painful, you're not having UTIs after intercourse, that she actually might change her mind about, her perspective towards her own sexual health at that time in her life.
Yeah, absolutely. I think, we know so much about mental health as we age and how important it is. We know that sexual health is a big part of mental health in relationships. And I think that it's a miss on our part as providers if we're not addressing it. Well, Kat, I know we could talk for many more hours, and we'll come back. We'll do more because there's so much more. I want to go deep with you on these things. Thank you so much for all of your knowledge. Anything you want to leave the audience with before we finish up today?
I think just to be curious, to arm yourself with as much information as knowledge as you possibly can, because it's important, and you are going to go through it. And you shouldn't feel ashamed about having questions or having symptoms and wondering if they're related. And also look at good, reputable sources for information, like the Menopause Society, formerly called the North American Menopause Society. As a patient, you can also go onto their website and get great information about symptoms, treatment, etc., and feel comfortable and confident that you're receiving the right information.
Awesome. That's great. And I'm excited. Next time, maybe we talk about different forms of hormones, compounded hormones, bioidentical hormones, like all those kinds of things that people hear about. We can even talk about estrogen for skin care. Like
Surprising.
there's so much to talk about. So thank you so much, Kat. We'll see you soon.
All right. Bye, Jared.
Bye.